This is a really exciting town hall today because many of us weren't, able to go all the way to Australia to attend IAS this year. So we're super excited to have 3 speakers today who are going to be telling us sort of about what was going on there, what happened, what's new in the science. What I'll do is I'll introduce right now our first speaker, and then before our second and third, we'll introduce them. So we're going to start today with Judy Auerbach, who many of you know. She is a sociologist who has taught, presented, and published across areas of HIV, social science, public policy, sex, and gender. Her work focuses on the social organization of scientific knowledge and the role and standing of social research, as well as community engagement and research and attention to women in the HIV response. Most importantly, last year, she was named as a fellow by the American Association for the Advancement of Science, which was amazing. And she'll be sort of giving us an overview, a broad introduction of the major social science, behavioral science, and implementation science topics. And then we'll get more in-depth views from Holly and Kris about some of the other topics of interest. So I'm going to hand it over to you, Judy.
Thank you, Sherry. And Holly is going to help forward my slides since I'm absolutely feeble at doing this. So thank you, Holly. And thanks for inviting me to participate in this report back. And as Sherry said, what I want to do is just talk about a few very broad themes rather than a lot of the very specific presentations and findings. And my co-speakers will address some of the more specific topics. And there are others in the chat like Carol who were there who can talk about even Carol's presentation if it doesn't come up. So we'll invite you to do that as well. And basically, in thinking about what's most interesting, I would think, to our community of CAPS and DPS, the overarching thing of my report back is really about centering science in community, which is something that is increasingly well recognized by the rest of the field. Some of us have been saying this for 40 years, but I think it's really catching on much more broadly as an understanding of what's essential. So with that in mind, there's 4 topical areas through some sessions that I'm going to present about. One is undetectable equals untransmittable, U equals U. Next is the role of critical social science, and I mean critical in the words of critique as well as of necessary. Critical has 2 meanings. Third, community engagement and leadership. And fourth, decolonizing HIV and public health research, which is one place where I think the other things come together. So I'm just going to report from a few activities and sessions in which I was engaged to make some general points about these things. So first, I was invited to attend a roundtable before the main conference began. This was hosted by the Australasian Society of HIV, etc. Medicine, ASHM, as you may know, in conjunction with a number of partners, including the Prevention Access Campaign, which is relevant because the theme was U equals U. It was a focused conversation about research policy and political priorities in U equals U. And the structure of the session was, it began with a keynote address by Kane Race, a sociologist from University of Sydney, who many of you know, and in fact is in the Bay Area with a sabbatical fellowship at UC Berkeley right now. And he spoke about U equals who, the hinterlands of biomedical prevention. I'll say more about that in a minute. Following his keynote, there were roundtables on research practice and policy issues and gaps. Then there was a report back from the roundtables. And after the main session, there was a launch event for a special issue of sexual health that I wanted to point out to all you who are interested on global evidence, impact, and implementation of U equals U, as it contains a number of articles by people who are attending and speaking at the workshop. So you may want to check that out. Next. So what came out of that meeting were some, in the first case, key points from Kane's presentation, a wonderful paper, really a critical social science evaluation of the construct and the application of U equals U. And his main points had to do with recognizing that the campaign has been so successful in, and I'm going to quote him a bit because his language is so elegant, condensing extraordinarily complex forms of socio-technical coordination between bodies, drugs, devices, programs, scientific practice, health systems, everyday schedules, into a moniker that is simple and provocative enough for diverse actors to attach to in local and global movements to transform the affective relations of HIV infection. So he captured in one sentence the crux and the beauty of U equals U. And then he made some other points about how U equals U desexualizes the problem of HIV transmission, and it turns it instead into a matter of engagement with medicine, clinical monitoring, and a pharmaceutical regimen, which is a major shift in the governmentality of the epidemic. It also acts as an ingenious lure, as he said, that is deployed strategically to bring about legal policy, health systems, and subjective transformation. It's a hook into some of these larger conversations. And for people living with HIV, U equals U enacts moral equivalence between self-care and altruism. In other words, by taking care of myself, I'm taking care of others. So these are all the fantastical benefits of this campaign, and obviously there was science behind it. But Kane also pointed out, as a critical social scientist, some of the paradoxes that come with undetectable status that are less well explored and examined. So, for example, in and of itself, U equals U does emphasize individual responsibility in HIV management in its own way through the requirement for strict adherence to antiretrovirals to achieve viral suppression. So that runs the risk of not actually addressing the social and structural barriers to treatment and care and to broader matters of distributive justice, meaning who has access to such treatment and care, who can visit clinics, who can make the time to visit clinics, not to mention some of the racist stereotyping and stigmatizing of sexuality in healthcare settings. So that's one paradox, the individualization for responsibility for HIV management. And then there's other paradoxes, including how undetectability itself requires a regime of detectability. So a regime of detection, U equals U presumes, and in Kane's words, presumes and conceals a vast hinterland of practical arrangements and relations, thereby simplifying the contingency in the context of these structural relations. In other words, you have to show up, you have to get tested, you have to get your drugs, you have to be monitored. So there's this whole regime of detection that comes with being undetectable. And that in and of itself, in relation to the prior paradox, doesn't put enough attention on the structural issues there. So there were others, but you get the idea. In the roundtables, there was a report back from the roundtables, and I'll just focus on some key points that came out of the research-focused conversations, as you can see here, about needing a broader agenda that does examine these larger, excuse me, social and cultural contexts and relations in which U equals U is embedded. The need for science, for both the science behind U equals U, the actual virology behind U equals U, but also the science of the health communication in the U equals U message. We need more research for populations that haven't really been explored. The question is still open on U equals U for breast and chest feeding, for example. And the importance of having a broad research and policy agenda that celebrates but doesn't entirely valorize U equals U for some of the reasons Kane had addressed. Next, please. So the next session that I wanted to highlight was a symposium in Track D, the social science and behavioral science track, that looked at social science and contributions of critical social science over almost 5 decades, over 4 decades of AIDS. And the speakers there were Gary Dowsett from La Trobe, Kane Race from Sydney, and Catherine Dawes from University of Bristol. The foci of this session included the social production of knowledge in HIV, understanding meaning-making practices, and looking at the importance of looking at wider structural processes that shape HIV responses rather than just individual level. And some of the specific topics the speakers addressed included stigma, U equals U, and global targets. Next, please. So some of the key points that came out of this session were obviously the indispensability of social science to the public health research response, particularly in drawing attention to social and structural forces and factors, which popularly are referred to as determinants and drivers, and revealing how the epidemic is shaped by knowledge systems, as well as cultures, politics, economics, and history, not just the virus and not just medical care. Kane Race talked about the need to move beyond slogans such as zero stigma, these targets and goals that are established globally and to which all of us are supposed to aspire, to consider the social processes that underlie the words in these constructs. So, for example, to really examine stigma as a construction and also the experience of it, because in the end, a slogan or a goal like zero stigma is fundamentally ridiculous if you know anything about stigma. Kane also talked about the importance of attending to the personal and intimate lives of affected communities in their specific localities to better understand these things like the targets, how they're set up, what they mean, how they're operationalized, as well as similarly for continuum cascades. Catherine Dodd provided a really critical assessment of the concept of stigma itself, and political, how it is, in particular, how it is used generally in our field in a very apolitical way, and how social scientists may even be complicit in producing and reproducing that. And in our own work, eliding the structural inequalities and power dynamics that underlie the whole process of stigma. And we can do that through things like, for example, the developing instruments and measures of stigma that don't really get into these social and structural realities. And so some of the great points in this session that came out in the discussion were really the need to reflect on who owns the means of production, meaning the means of knowledge production in research, and who gets to share in the power. And that led to reference to decolonizing research, which I'll mention in a minute. There was also a point made about how current and impending crises, such as global climate change, the rise of authoritarian regimes, the threats to LGBTQ communities, and so on, that intersect with HIV and other pandemics, absolutely require greater investment and greater attention to critical social research. Next, please. Another symposium that I was actually invited to be the moderator of was a Track E Implementation Science Symposium on community-led models of care. And the speakers were Simran Barucha from Indian HIV/AIDS Alliance, Donald Brown from Hopkins, and James Ward from the University of Queensland's Poche Center for Indigenous Health in Australia. And that session focused on how community engagement with a focus on social determinants of health informs the design and implementation of feasible and acceptable models of care. And within that discussion, the speakers focused on gender-affirming care, Indigenous peoples' access to sexual and reproductive care, and peer-led models. Next, please. Some of the key points that came out were from Barucha about how non-HIV entry points, such as gender-affirming care and legal and social services, can provide opportunities to enroll gender diverse and other people in HIV prevention and care. And she mentioned how 1/2 of her clinic's clients previously lacked access to care. So before they implemented these other kinds of services, they were not accessing HIV care. Ward talked about Indigenous populations, particularly rural populations and others, and said how we need to move beyond volunteer and casually employed peers to instead employ members of the community in ongoing roles. This is not news to all of us at CAPS. Peer-led models are promising, but need to be scaled up and made sustainable and funded. Brown talked about the need to listen and attend to the underlying and seemingly peripheral issues of concern to drug users themselves and their communities, including food and housing insecurity. Again, something folks here do very well. And said specifically about one-stop shopping, service delivery requiring collaboration with non-HIV social services. And so in the discussion, the general point was about how HIV can be a model for addressing the fundamental causes, which is what Lincoln Phelan originally theorized in talking about social drivers and factors and determinants of health, if communities are listened to and fully engaged. Next, please. And so finally, Track D had a symposium on decolonizing HIV science, which is a conversation that many of you probably are engaged in and is becoming quite an area of focus in our field. We had, unfortunately, only 2 pre-recorded presentations. The speakers were not able to be in Brisbane. Many speakers could not because of the cost, but in their case, given their geographic distance from Canada to South Africa, they couldn't even be live as presenters at the meeting. So we had pre-recorded presentations and then an open conversation I'll mention in a minute. And the presenters were Amaya Perez-Brumer from the University of Toronto and Devi Abana from the University of KwaZulu-Natal. And the focus for both of them was about interrogating HIV knowledge production from a decolonization lens. And they talked about the researcher standpoint, how researchers themselves participate and also need to be aware of how to transform decolonizing research. And then the ways in which we do this inadvertently through theory, method, data management, and the governance of research. Next, please. And the key points that were made from Maya Peresbrumer were the need to pay more attention to the context in which research is conducted and ask questions of for whom, by whom, and for what the research is taking place. And you could see, if you can see the picture in the last slide of her, her lead thing was, is global health about health, or is it about data collection? And she made the point that Western or Northern researchers must examine the role they play in the perpetuation of inequalities, in particular focus on the extraction of data and data governance and management and how that happens when it's taken from communities. Devi Abana talked about the need for researchers to adopt a decolonial perspective and center the experiences and the needs of communities in their research. And that requires acknowledging historical injustices, addressing power imbalances, and engaging in collaborative partnerships to transform the landscape of research, prevention, and treatment. And we ended up having an open discussion with all the participants in the room because the speakers weren't there to respond. And in that discussion, it was actually quite great. It was nice. More people got to get up to the mics and say what they wanted to say, which was good. And out of that came a general, conclusion about the importance of centering communities, being sensitive to cultural diversity, and promoting access to information, knowledge sharing, and collaboration as essential components of decolonizing research. And after the presentations and the discussion, people felt that we still didn't have really good examples of when and how this has been done. So we look forward to that. And I think with that, next, please. I just wanted to thank Kane and Daniel Grace who gave me their notes. And thank you all for your attention. Hand it back to Sherry. Thanks, Holly.
Thank you, Judy. I think what we're going to do is hold questions until all three speakers have had a chance to share, and then we can get to a longer discussion with everybody. So I'll go ahead and present our next speaker. We have Dr. Holly Nishimura. She is a social scientist and a second-year postdoctoral fellow in the TAPS program. And she's focused on understanding and intervening upon social and structural factors that contribute to health inequalities globally. Her research mainly focuses on improving male engagement in HIV prevention and treatment programming, and also economic interventions such as guaranteed income to improve health. And Holly's going to cover more in-depth differentiated service delivery strategies for HIV prevention. So with that, I would like to hand it over to Holly.
Thank you, Sherry. And thank you to CAPS for allowing me to attend this conference. It was such a wonderful experience, and I learned so much. So I hope to give you a brief overview of what I learned. And I am not reporting back on the Decolonizing Global Health session, but I want to give a shout out to Judy because she did such a good job of facilitating the session, even though none of the speakers were present. Okay, so here's my presentation. And like Sherry said, I will be focusing on differentiated service delivery, mostly related to HIV prevention and a little bit on treatment. Okay, so just an overview of differentiated service delivery. This framework is recommended by the WHO for service delivery. And when we talk about differentiated service delivery, it includes 4 building blocks. When, referring to how often services are provided. Where, referring to in what location services are provided. Who's providing the services, that can include lay, community health workers, physicians, etc. And what does the package of services include? And also, this is a great resource, differentiatedservicedelivery.org, if anybody's interested in exploring this topic more. So first, I'll cover a couple oral abstracts from this differentiated differentiated service delivery with focus on PrEP session. So this group related to who studied pharmacy-led oral PrEP refill visits in Kenya. They had a huge presence at the conference. I feel like almost every session I attended had somebody from this group. So basically they offered PrEP refills directly in pharmacies so that clients did not have to attend or go to clinics to get their refills. They found high acceptability of this pharmacy delivered oral PrEP among both clients and providers. They found that a total of 35% total time spent at the clinic was reduced, and then increased PrEP continuation, specifically 23% continuation in the intervention versus 16% at the control at 6 months. They'll be doing an upcoming pilot study, which will test adding Cab-LA to this model of pharmacy delivered services. This is another oral abstract from the same session. So this is PrEP and service utilization among sexual and gender minority youth. And these youth were recruited from sites in Los Angeles and New Orleans. The intervention was a 4-arm factorial RCT. So the 4 arms involved automated messaging and monitoring, which they refer to as AMMI. And this occurred via text message. And group 1 was the control group. And then they had the AMMI plus peer support via private social media, the AMMI plus strengths-based telehealth coaching, and then the AMMI plus peer support and strengths-based coaching. So their most significant finding was the AMMI, the most intensive treatment group, the AMMI plus peer support and strengths-based coaching, doubled and sustained PrEP use compared to the control group, which was just the AMMI via text messages. And I thought this was a really innovative design to try to tease out how effective each of these strategies were. Next, there was a satellite session on implementing low barrier care for patients with complex medical and social needs who are not well engaged in HIV care as it is traditionally organized. You might recognize these names from UCSF. There was Elise Riley, Matt Hickey, Elizabeth Imbert, and then folks from the Max Clinic at the University of Washington, Julie Dombrowski and Meena Ramachandrani. They define low barrier care, which included structural elements such as walk-in access to care, in which no appointments were required, and then an integrated care team with case managers, and then also providing incentives to clients. And process elements for this low barrier care model included adopting a low barrier care philosophy, multi-sector coordination, and also integrated care, and then a commitment to rapid modification to meet the needs of the clients. So the patients attending these clinics were mostly those experiencing homelessness or housing instability, mental health issues, and then also substance use disorders. For the pop-up clinic at Ward 86 in San Francisco, this was launched in 2019, and they have enrolled 211 virally unsuppressed patients. At follow-up, 75% had reached viral suppression using this low barrier care model. In the Max Clinic, which also used a similar low barrier care model, they enrolled 375 patients, and then 82% achieved viral suppression compared to 65% in the standard of care. Okay, now I'm going to take you back to Africa and discuss oral PrEP acceptability study. Oral PrEP versus depivaring vaginal ring acceptability and feasibility study. So this group conducted a 2-arm prospective cohort study and examined the acceptability of the depivaring vaginal ring compared to oral PrEP among adolescent girls and young women. They enrolled about 1,400 young women. most young women preferred the depivoring ring. And most of the women that preferred the ring were in rural districts compared to urban districts. And they said that it was easier to hide the use of this HIV prevention method. And continuation was consistently higher among AGYW who chose the ring compared to oral PrEP. Okay, next, this was an oral abstract session called Designing Services to Optimize Delivery of PrEP for All Who Would Benefit. This is another abstract from the pharmacy group based in Kenya, I believe. They assessed anticipated preferences for long-acting pre-exposure PrEP prophylaxis among clients who were getting their oral PrEP refills at pharmacies. So they surveyed 491 of those clients. 58 reported a preference for injectable PrEP, and most of those were males. When they asked females to rank their preference of all of these prevention methods, most females, 57%, said that their first choice would be injectable PrEP, followed by oral PrEP, and then the depivoring ring, which is interesting compared to the Zimbabwe study that we just looked at, showing that there was a much higher preference for the ring over oral PrEP. Next, this was another oral abstract session related to evaluating drivers of pre-exposure prophylaxis choice for transgender women in 11 Asian countries. This study enrolled about 1,500 transgender women. It's one of the largest choice studies that have ever been conducted among transgender women. They identified the most important attribute of service delivery as cost, with 62% relative importance. And in terms of the combination of services, or how they wanted services to delivered, most wanted PrEP that was free, injectable, with no side effects, offered in a peer-led community clinic, which also provided STI testing and only required 6 to 12 monthly visits. And if this service was provided, they predicted the uptake to be at 87%. So next, I apologize for this really tiny picture of the poster, but I figured I'll send out the slides and you can zoom in if you want to see the exact figures and wording in there. So this was a interesting poster presentation on the acceptability, feasibility, and preliminary effectiveness of a courier service for HIV treatment delivery in South Africa during COVID-19. So they enrolled 215 young people living with HIV in Cape Town, South Africa. Sorry if you can hear my dog. 82% elected to enroll in the courier service, and about half were receiving ART delivery at the 6-month follow-up period. Most rated the courier service as highly acceptable, and then participants who reported receiving delivery in the past 3 months, who were evaluated at month 3, were 1.26 times more likely to have to be virally suppressed. But they did not find any effects on viral suppression at month 6. Okay, so this is not as related, but there were a couple sessions that focused on social network-based interventions for HIV testing that I wanted to highlight. One was a systematic review and meta-analysis that included 43 unique studies. And they found that there was that social network approaches were associated with increased uptake of HIV testing. And in other evaluations, they found that this approach was highly acceptable and cost effective. So this is actually recommended to increase uptake of HIV testing in a range of populations. And then Carol Camlin, who's here currently, did an oral abstract and was selected as a co-chair's choice to present the Awete study, the findings from the Awete study, which is a social network-based intervention and was found to increase HIV self-testing and linkage to health facilities among fishermen who are a high priority group in Kenya. So the results from this study were that in the control, let me explain the intervention. So basically, men were divided up into social network clusters based on a social network evaluation. Promoters from each social network in the intervention cluster distributed HIV self-test kits and transport vouchers to their cluster members. And then control clusters, promoters received HIV information and then distributed referral vouchers for free self-tests to their clusters. So we found that in the intervention clusters, HIV testing via HIV self-test kits was 60% compared to only 10% in the control clusters. And then linkage to facility for either HIV treatment or PrEP was 70% in the intervention clusters compared to 17% in the control. So here are some takeaways and future considerations based on the sessions that I attended at IAS. I noticed that adapting service delivery and retention strategies to meet the context, circumstances, and needs of clients, for example, low barrier care and pharmacy delivered prevention methods were highly important. Providing clients with choice, and there is more choice now in the form of the deprivering ring, oral PrEP and injectable PrEP, and understanding client preferences was highly important for developing these service delivery interventions. And then harnessing social networks could be an important tool to reach hard to reach populations for HIV testing. And that's it.
Thank you, Holly. That was a great tour de force on a lot of really important oral abstracts and a couple of posters. So I'm glad you got to attend and see so many different things. Okay, great. So we're going to move on to our final speaker, and then we should have about 15 minutes for questions, or maybe 10. So Dr. Kristopher Jackson has a PhD in nursing, and he's currently a TAPS fellow here at UCSF that just finished his one-year epidemiology degree at his MPH at Cal. Dr. Jackson uses novel data collection methods to gain insight into hidden or stigmatized populations of people at risk for HIV, with a specific focus on MSM sex workers, and also studies advertised risk and health-seeking behavior among internet-based MSM sex workers. He's going to be talking to us today about patient-centered PrEP care, describing factors that affect PrEP uptake and adherence among varied global populations at high risk for HIV infection. And with that, I will hand it over to you, Dr. Jackson.
Thank you so much. I, like Holly, was one of the IAS scholarship recipients, so I am obviously quite grateful for the opportunity to have attended. My presentation is set up slightly differently, and we are just going to, let me switch my screens here. Excellent. So, okay. Thought this would be working. Hold on. So, yes, so today we're going to be discussing person-centered considerations for PrEP care in the era of choice. Today, I'm going to very, very quickly kind of just present the concept of choice just as sort of my framework and how I picked the presentation, the presentations that I put into this talk. Spend 2 seconds talking about what my personal goals were for IAS, discuss 4 sort of what I thought were very important study findings that were pertaining to choice, some of which I think you probably heard about very briefly in Holly's overview. We'll go into a couple of those in greater depth, and we'll talk about future directions, and I'll give you a quick recap of my thoughts. And so I'm presenting here the concept of choice. Over the last 10 years, obviously, the landscape of HIV prevention has changed quite considerably. We went from having one agent to offer as PrEP to two, to on-demand, to injectable, and with new emerging therapies on the horizon. And I think with greater complexity comes more choice. And while that can certainly make HIV prevention maybe seem more complex, it also offers us the ability to reach more people that perhaps we weren't reaching before with prior methods. So most of my work is domestic, again, focusing predominantly on US-based MSM sex workers. And so as I was getting ready to sort of wander into the global waters at IAS, I was trying to get a sense of like what other nations, what other countries, what other areas of the world there's like a significant amount of PrEP uptake happening. And so here you can see this map with the sort of darkest fuchsia colors being the great areas of greatest uptake, noting the US, Brazil, Eastern and Southern Africa, Southeast Asia, and Australia. And that map is significant. It will come up again. And so I am really interested in choice from the standpoint of this sort of pathway, which is a bit of a shameless plug because this is featured in a piece that I wrote that's being published in Public Health Reports next month. And obviously on this causal pathway, you could probably all think of about 100 other things you could put in here, but I'm particularly interested in person-centered PrEP regimens as an opportunity to increase PrEP prescribing and sort of reducing HIV transmission and meeting EHE goals. And so these are the 4 studies that we're going to talk about today. You'll note that they are all from areas of greatest PrEP uptake on the map that I showed you earlier. And we'll go into a little bit of the methods and some of the findings in greater detail. I think 2 of them probably look a little familiar. So this was the dipivirine ring study that was mentioned, the evidence from Zimbabwe. I think it's important to note that this was a mixed method study. And again, we were basically something like 1,200 adolescent girls and young women were counseled for both dipivirine and oral PrEP. So they were given information about both therapies and then given the opportunity based on the information provided to choose what regimen they felt would work best for them. Participants selected the dipivirine ring at a rate of about 3-to-1. And what I think is really interesting is, and here, as Holly pointed out previously, was sort of after that 1-month follow-up, you started to see these the difference in continuation rates become more discrepant over time, with a difference of about 47% by about the 6-month return visit. And so in addition, I think there were some key study findings here. And I know Holly mentioned the difference in terms of the rural versus urban difference, with the dipivirine ring being more preferable among rural dwelling individuals in Zimbabwe. I think it's really important to also note that the pill burden and the discretion were factors. Also, there was some qualitative evidence that was presented around this paper around intimate partner violence as a factor to dipivirine ring failure, or women removing the ring out of fear or concern for their partners disliking it. So this was a very interesting subgroup analysis from Brazil, looking at some data that was collected in the context of the IMPREP study. So this was a very interesting open label multi-center PrEP implementation study being conducted in Brazil, Mexico, and Peru. Here the authors presented findings just from the Brazil arm. So we had a sample of here of just under 4,000 MSM and transgender women in Brazil, with MSM representing the biggest bulk of the sample there. And the primary purpose of conducting this analysis was to look at factors affecting non-adherence among MSM and transgender women in Brazil. I think before we get into the study findings, it's worth noting that the study composition was about half white and about half Black or Pardo, Pardo being the census category that Brazil maintains for mixed race and some indigenous populations. And so here we found that non-adherence was higher among the Black and Pardo participants as compared to the white participants. And another significant finding here was that those with lower educational attainment or who are engaging in transactional sex actually exhibit higher odds of PrEP non-adherence as and then in all racial and ethnic categories in the study, transgender women as well as younger individuals exhibited odds of PrEP non-adherence, regardless of race. I really liked this study as well. So this was again an offshoot from the HIV Prevention Trials Network Study 084, which I think many of us on this call are probably familiar with, that showed Cabolet was superior to oral TDF for HIV prevention in individuals who were born female. And so in 2022, participants were offered enrollment in an open label extension with a choice of either continuing on with CAB or switching to TDF-FTC or vice versa. So of the randomized groups, about 94% of those participating were deemed eligible. 81% were then ultimately participated. And drum roll, please, if we guess what people selected. Overall, by and large, 78% of participants chose CAB, 22% ultimately chose oral PrEP. Of those who were initially randomized to oral PrEP, 67% chose CAB or made the switch over to CAB. Conversely, those who were already randomized to CAB, very few, or 11%, moved themselves over to oral PrEP. And so what other factors drove this choice or the decision to switch, or ultimately drove patient product choice? One, individuals who were sexually active but not living with a partner were more likely to select CAB than oral PrEP. Individuals who'd experienced physical intimate partner violence over the last 6 months were also more likely to choose CAB versus oral PrEP. And finally, those who had been paid for sex in the last month were more likely to choose CAB over oral PrEP. So again, by and large, the individuals here who chose CAB, they preferred an injection over a pill. They thought it was more convenient. Conversely, those who were taking pills preferred a pill to injection and didn't like needles or the resultant injection pain or side effects. So I don't think those studies are terribly surprising, but still worthy of documentation. And I know that Holly also really briefly touched on this 11-country discrete choice experiment that was conducted across Asia. But again, the idea here was to evaluate the attributes that drive individuals to use PrEP, but also the combination of attributes that would make PrEP most palatable or most likely to be used. So in this large sample of transgender women that was drawn from across Asia, something just over 1,500 individuals, we found that in terms of the sample composition, just about half reported ever taking PrEP, but very interestingly, only 10% were actively taking it at the time of study participation. They were given sort of 3 PrEP options, which was daily oral versus injection versus implant. And the experimental design of that study was quite interesting in that it was based on this random parameters logit to sort of assess what the relative importance of the various attributes of each PrEP delivery method were, to sort of establish what the best combination of attributes would be in terms of both delivery and medication attributes. And so I know Holly touched on this again very briefly, but I wanted to dig in a little bit deeper and saying that yes, the best combination here was injectable PrEP that was delivered in a culturally competent setting, had no cost, and was administered at the longest interval possible, with the opportunity to complete STI testing at the same time. Cost was among the most important drivers of PrEP use across transgender women in Asia, or from the 11 countries who were sampled. I think it was also quite significant to note that transgender women who were more vulnerable to HIV were more likely to use PrEP if they had access to it via telehealth. And so again, I'm sort of presenting all of that like rapid fire information and sort of representing to you the concept of choice and the individual level factors of the various populations that I've talked about today and how their PrEP choice could be driven by various factors that we can measure and those that we can't in each of their lives. And so when we're thinking about person-centered prep regimens and what works for whom, today here in the United States, because I'm bringing it back to some of my own domestic work, we have oral prep, we have daily, we have on-demand, we currently have Cabalet as an injection offering. And so these are some of the factors that we've established at a global level seem to impact prep choice or what delivery mechanism works best for their life. After my time at the conference, I started thinking a little bit more about additional factors or ways that we could branch out beyond that. So recognizing that, sexual orientation as a category could mean many other things, and there's many, many subgroups worthy of further analysis there. Similarly, other factors that were not measured, things like internalized homophobia, et cetera, that might limit PrEP uptake among groups of MSM, specifically thinking about my work as sex workers, recognizing that individuals who engage in indoor-based sex work versus outdoor sex work versus digital sex work all carry different levels of risk. And I'm sure as I was talking, you're thinking of things you could put onto this grid. And so I think that the idea here is that the concept of choice is among us and it is here to stay. And the number of choices we have are going to continue to grow as a function of time. So in summary, I think it's quite evident, and I think I'm screaming into an echo chamber here, but PrEP is not a one-size-fits-all endeavor. Many of the international studies I've presented here have very important domestic implications. Many studies presented at IAS this year suggested that person-centered approaches to PrEP prescribing are absolutely crucial to adherence. And then certainly as new regimens become available, new patient-level factors are influencing adherence, that influence adherence rather, and uptake will continue to change.
Great, thank you.
Thank you.
I really appreciate all three speakers. Judy's sort of broader introduction and Kristopher and Holly's moving in on very specifics. And I want to open the floor to questions. And as folks are raising their hands with questions or putting them into the chat, I might just start us off. And I did want to go back, Judy, to your discussion of the decolonizing global health discussion. And just sort of, I'm curious whether folks focused on how sort of this colonizing structure is produced and reproduced by the structure and the actors. And, as researchers, we work within this sort of colonized structure. And, a lot of us are NIH funded, and NIH just put out this new requirement for all of our subawards that we have to take all of their lab notebooks and pull all their data. And it's it feels like we're being forced to continue a colonizing structure, even when we don't want to be doing these things. And so I'm curious how that was discussed at the meeting and what people had to say about that.
Well, it certainly was. Thanks for your question, Sherry. And thank you to my co-presenters. You guys were great. That was really, really good. Yes, and there's multiple conversations occurring, and I think it would be remiss for social scientists to have the conversation without addressing the structure that sort of forces colonized research or colonizing research on those of us who wish to not be colonizing. So one thing I will say, because I can't remember all the specifics of the presentations, is all of the conference content is now available online for free to anybody. It's publicly accessible. So you can go to IAS 2023 and you can look up all the sessions, you can view the videos and of whatever presentation you're interested in, and probably the posters as well, and the summaries, the abstracts, and so on. So I think these were some of the key issues folks were talking about, is how do you at the same time do your work, get your job done, including employing people in settings where they may not otherwise have employment opportunities, and engage in what you would prefer as a researcher sensitive to the colonizing aspects of research. And so I think what they would have said would be about starting with self-reflection. Where are the places that you can have some control? And those are everything from how you engage community from the start in defining the research questions that are of interest to them, not necessarily to you, but obviously there'd be some overlap. And engaging with employment, people from local communities. These are things that most of you all do. But there are also all these issues around data management, and I can't begin to unpack all of them since I don't do this kind of work myself. But I think paying attention to how the data are collected, abstracted, and then what happens to them is a huge area where you might be able to control some things, even at the same time as, unfortunately, NIH is asking you to kind of do the opposite to some extent. So raising these things to the NIH obviously are important to do as well, being advocates around these sorts of issues. One thing I would also mention is the researchers from high-income countries are many of them very sensitive, who are looking at this, are very sensitive to their own positionality in the whole proposition. And one question and a couple articles have been written about where are the African or where are the Latin American, where are the Asian scholars on all of this. There is a group in Africa that's kind of emerging on decolonization, and I will find the web link and I'll send that to you. And there are a couple of articles as well. If you're interested, let me know and I can forward those. But where folks in these countries are talking about how do we take over basically the research that is in and of us.
Thanks, Judy. I see Holly's got a hand up.
Yeah, I just wanted to add, again, this was such a well-facilitated discussion because the presenters weren't there in person. It was just all remote. And I think the presenters were mainly focused on arguing for the need for decolonization and incorporating self-awareness, critical self-reflection into your research practice. But I felt like the audience, and correct me if I'm wrong, Judy, I felt like the audience felt like we were beyond that already. There's no longer a need to argue for decolonization. People there acknowledged that it should happen to rectify some of the inequalities that happen in global health research, and how do we operationalize it? And I felt like that's what I took away from the session.
Yeah, that was the key point, that there were not, the speakers themselves did not present, and people felt in the discussion, I can't recall, I think a couple people gave some examples of what they're doing, but we're sort of bereft of concrete examples about how to enact decolonizing practices. So that's why I'm going to send a couple of the articles, but you're absolutely right, Holly. I think the session ended with somebody coming in the room and saying we should start by decolonizing the IAS, which of course got around passing applause.
Right. And do you want to give folks an opportunity to ask questions? I have many more if no one raises their hand. There's Carol. Okay.
Hi, just really briefly, I just wanted to mention that in some of the sessions around pharmacy-based delivery in Kenya, which, you know, there were a number of them, and that was a real kind of headliner. I was just really interested in some of the discussion that happened that no one has really remarked on beyond those venues yet, but around the kind of checklist for eligibility and major gaps between persons who desire PrEP or would be eligible for PrEP and are not deemed eligible, or aspects of stigma related to the process of being evaluated for PrEP eligibility. And I just want to kind of flag this as something that I think will require actually some good solid social science research, because I think these little clinical checklists are just another tool that funnels people into the health system that in many settings may be becoming a barrier. And the kind of like ways in which providers are interacting with these checklists, how the interactions are happening between providers and patients or clients, all of that I think has not yet had any attention at all, and probably needs attention. So I just want to kind of highlight that.
Thanks, Carol. I did want to ask Holly and Kristopher quickly about the preference. Sort of, both of you presented these two studies where davirapine ring was like much more, you know, preferred in one and less in the other. And I do want to just ask about, you know, preference and intention is very different from use. So I'm just sort of curious, I don't know if those studies were presented in the same session, but I'm curious about the discussion around what people say they want and then what they actually utilize once it's been introduced. Either one of you, yeah.
I can just say that the Zimbabwe study, in the Zimbabwe study, the AGYW actually did receive the depivaring ring and used it. So it was actual use rather than intention. And the other one, the other preference study was solely based on intention among people who are already using oral PrEP. So very different populations and also study methods.
I also think that the actual use study of women in Zimbabwe using the depivaring ring, it's really important to notice that like there were actually probably, I think it was like 4 seroconversions that were noted as a result of either removing the ring or like not having access to the ring. And so it kind of does beg the question in terms of like, yeah, in practice, this seems great. But then in terms of like on the ground implementation, how does this work? You know, if you're removing it so that someone can't see it or find it, or you hadn't thought of that, or that hadn't been counseled, or simultaneously, if you were like traveling and thinking like, oh God, I didn't think about, you know, where I was within the 28-day period, you can see how that actually has like very deleterious effects. So actual use, yes, but it does sort of beg the question of, and we don't really know, right? But just in terms of what like the teaching was, what the counseling was like, what, you know, those sorts of things that like actually sort of might impact the sort of success of the intervention.
Yeah, I also have to question, like, when they introduce these things, like really being able to hold it, see it, think about it is different from just being like, imagine you had this ring, you know.
Yeah.
I don't know exactly how they did the study, but we always have to be careful about interpreting those choices or the preferences when there's not an actual product in front of them. Any other, actually, we're at time here. So I guess instead of asking for any other questions, I'll just thank our 3 speakers. Amazing. I feel like I was there and I got to hear all about what was most important at IAS. So thank you a ton for presenting back to us.